Thank you, Marianne and Bob. It's really a pleasure to be here today, and thank you very much for everyone to come today. It's a pleasure to join great speakers that I'm sure I'm going to learn a lot from them today as well. And I would like you guys, hopefully, to have a great benefit about education of neuroendocrine tumors, what is the new trials we are expecting, and how we treat this type of tumors, given they are very different from any other types of cancers. So what I'm going to talk about, it's a brief summary about how we treat neuroendocrine tumors, how we diagnose them, how we treat them, and then for every single treatment, what type of clinical trials we're expecting to come in the near future, and we're expecting, hopefully, to change the landscape of how we treat neuroendocrine tumors. So the first question always comes to my patient when they visit my clinic. I have been here that they are very rare cancers. And this idea of neuroendocrine tumor to be rare have been in the mentality of many patients for a long time, and even for medical professionals. But believe it or not, I don't think that's the case anymore. So neuroendocrine neoplasms are one of the most common GI cancers after colorectal cancer. If you see here the graphs in the right and left, the one below is the neuroendocrine neoplasms. And if you compare it with colon cancer, breast or lung cancer, they are definitely less common than them. But if you want to see the last 25 years, there is significant increase in the neuroendocrine neoplasms. One of them is environmental factors. One of them, we have much better diagnosis modalities that we can catch these patients earlier. We have much better treatment, patients living longer life. So we see more and more numbers for patients with neuroendocrine neoplasms. And interestingly, all the types or the subtypes of neuroendocrine neoplasm has been increased, whether it's coming from the lung, small bowel, pancreatic. We see more and more number for all these types of patients. The diagnosis of neuroendocrine neoplasms has been significantly changed starting in 2017 when they subcategorize the high grade or grade 3 to be a grade 3 well-differentiated and grade 3 poorly differentiated. Starting in the pancreas in 2017, and then 2019, it included all the GEP-NET, or the gastroenteropancreatic neuroendocrine tumors. So if you want to have an accurate classification of neuroendocrine neoplasms, you see that you have the well-differentiated, grade 1, 2, and 3, and we have the poorly differentiated, which is always grade 3. So we have the NET and the NEC, neuroendocrine tumors and neuroendocrine neoplasms. Differentiation, very simply, mean when they took your biopsy, how does it look like under the microscope compared where it's coming from. If there's a lot of similarity with some morphological changes, but you can see the group of cancer in group of cells, that's how we name it well-differentiated. Poorly differentiated, just as sheets of small cells spread all over the place. They're looking very aggressive, completely different from where they originate from. So this is a neuroendocrine carcinoma. It's very important usually to ask this question, do I have neuroendocrine tumors or do I have neuroendocrine carcinoma? Because diagnosis and treatment are completely different. The outcome as well are completely different. So this is just the accurate terminology now, instead of just using carcinoid. Neuroendocrine neoplasms are the big umbrella. Neuroendocrine tumors, these are the well-differentiated, and neuroendocrine carcinoma, these are the poorly differentiated. So what are the treatment options, even in metastatic setting? And I'm going to concentrate mainly in the well-differentiated. Some of our patients, even the patient who have metastatic GEP-NETs, we still include our surgeon for this patient. There's a lot of data showing that if you can do a surgical cytoreduction, which means you can remove up to 70 or 90% of the tumors, it definitely improves the survival and improves the outcome for your patient, even if they are metastatic or stage 4. So definitely we try to discuss most of these patients in the neuroendocrine tumor and see how safely can we really do this type of surgery for our patients. Some patients who have mainly liver mets, we send them to our intervention radiology and we do what we call liver-directed therapy, whether this is radioembolization, chemoembolization, slightly less commonly used, and it depends from one institution to another, microwave ablation. And that's mainly for the patient who have mainly metastatic in the liver and the progression was mainly hepatic, not extrahepatic. The patient who have both hepatic and extrahepatic, we try to use more systemic therapy. And the main 4 category of systemic therapy that I would like you to remember is basically, let me just go back. is basically the somatostatin analog, radionuclide therapy, targeted therapy, or chemotherapy. So again, when we're using surgery for our patients, basically if you have a localized neuroendocrine tumor, especially in the small bowel, I try to send all these patients to our surgeon to avoid bowel obstruction or other complications. Because sometimes even if you're secreting some serotonin, that's by itself can causing a lot of fibrosis or mesh around the cancer and can put you at risk of bowel obstruction. So it's better to send this patient as early to your surgeon. Also, if you are pancreatic and more than 2 centimeters, we usually send all these patients to our surgeon. Sometimes if the lesion between 1 and 2 centimeters, it needs more discussion at the tumor board to see which patient are higher risk that we would like to send to our surgeon as well. And again, if you are metastatic and we discuss the case in the tumor board, then we can go ahead, remove the primary tumor and do a safely cytoreduction. We definitely recommend surgical consultation for these patients as well. So the main 4 principles of all our systemic therapy, do you have somatostatin receptors, which basically, do you have a specific lock above your cell that we can use it either to lock your cell from growing or hopefully even to look at a longer time by using the peptide receptor radionuclide therapy with maybe some shrinkage as well. Or if you have specific mutations, we know that the mTOR mutation, it's mainly for pancreatic neuroendocrine tumor. About 15–20% of the patient either have the mutation in the mTOR or downway the pathway of the mTOR itself. It also works in other types of neuroendocrine tumor, as we're going to see, like lung neuroendocrine tumor, and sometimes in non-functional, non-pancreatic or non-bronchial neuroendocrine tumor. It doesn't really work very well for someone who have a functional small bowel neuroendocrine tumors. Sunitinib is another treatment that we use also mainly for pancreatic neuroendocrine tumor because that's where we have the data for. And chemotherapy, again, mainly for patients with pancreatic neuroendocrine tumor because overall the response is much better than someone with mid-gut or even thoracic neuroendocrine tumors. So this is the 4 main categories that I'm going to discuss. Them, what do we have currently, and what is the options of clinical trials that's going to improve this standard of care or maybe answer some questions that we don't know about. So again, somatostatin receptor, usually I use this picture to discuss to my patient when I see them in the clinic. Would like to know if you have this lock above your cell or not. How we can know that? By doing the PET scan, whether it's a copper-64 or gallium-68. And we always would like to discuss this patient in the tumor board to see how intense is the expression. Because really, a lot of data now that we know that the intensity of somatostatin receptor and to be in all the lesions, that's very predictive for how much benefit you are going to get either from the shot or the PRRT. So this is the first piece of information that I would like to know for our patient with well-differentiated neuroendocrine tumors. And then after that, if you look at the data for somatostatin analog, whether octreotide or lanreotide, it started initially with hormonal control, and then we have a phase 3 data did show that they delay the tumor growth. They delay the progression of the tumor. So we have the PROMID study and we have the Clearance study using the octreotide intramuscular or the lanreotide subcutaneous. And when you compare it with placebo, there was significant difference in progression-free survival. So when we are going to use any of them, we use them for patients who have somatostatin receptor positive, well-differentiated GAPNet, gastroenteropancreatic neuroendocrine tumor. Use them for 2 reasons. Number 1, you want to help with the symptoms. You want to delay the carcinoid features, but also you want to delay the tumor growth as well. I am trying to emphasize on that because a lot of patients come to me and say, I don't have any symptoms. Why you want to give me the shots? Because the data did show that when I give you the shot, it will delay the progression of your tumors. Most of these patients will not have a high tumor burden, which means if you have a lot of lesions, more than 25% in your liver and extrahepatic, the shots by itself sometimes is not enough, and we have to discuss other options of treatment as well. So usually these shots for someone does not have high tumor burden, he or she, they have the somatostatin receptor positive lesions, and they are metastatic GAPNet approved as a first-line treatment. For the hormone secretion, if the patient is still have, I don't know what's going on with the screen. If you still have symptoms, there's a lot of other options. These are rescue shots, and I specifically put the Benfesia because I'm still getting this question for some of our patients. Rescue shots, they can give it up to 3 times a day. It does help with diarrhea and flushing. At one point, we have a very good option with using the Benfesia pen, which was much easier for our patient. For some reason, we don't really have this option anymore. I don't know what is the reason exactly, but the company is not producing this medication in this form anymore. But the rescue shot itself, that it can come in vials and syringe, you still can use it up to 3 times a day. Also, the telotrestat or Zermello, which is going to inhibit the formation or the synthesis of the serotonin itself. We also give this oral medication, and the phase 3 trial have shown that it decreases the carcinoid features if someone refractory to the somatostatin analog. And we have some data about amino acid drink called the Entrade, which also can help regeneration of the intestinal barrier of the patient and can help it to decrease the amount of diarrhea they have. Some patients of my patient, I put them in the Entrade, and they get some benefit from decreasing the consistency and the frequency of diarrhea. So these are options always. If you are in the shot and you still have diarrhea, you can ask your physician about. So again, the telotrestat or Zermello, it's basically a medication to inhibit the tryptophan hydroxylase, which is the main enzyme to form the serotonin. And serotonin is basically the hormone of happiness. You know, it makes everything happy in your body, including your gut. So it increases the motility. The patient will have a lot of diarrhea. And basically, if you can try to decrease this type of hormone, you are going to decrease the frequency and the consistency of the diarrhea for your patients. And the phase 3 trial have shown and proven that in the patient who have 4 power movements or more, when they took the Zermello, it definitely decreased the amount and consistency of diarrhea for this patient and the carcinoid features overall, and improves the quality of life. So this is our phase 3 trial, and in addition, also there is some evidence, coming a real-world evidence, did also show that it decreased the amount of bowel movement and it decreased overall or improved overall the carcinoid features. So one of the oral medications that I use for my patient, sometime in addition to that, if the patient have a very high serotonin, more than the 300 level that I try as much as I can to keep the serotonin by 300 level or less, I try to put them in Zermello as well to decrease this type of hormone secretion. So what is new? This is the main first somatostatin analogs that we use for our patient. One of them is the oral somatostatin. If you can using something like paltusotine, one of the very novel treatment, which is an oral medication. Now it's in a phase 2 study in 2 doses, either the 40 milligram or the 80 milligram. The aim of the study is mainly to show that it decreases the carcinoid features. So when I describe it to my patient when they come to the clinic, I say, technically, it's the same medication, the same shots. It's just in oral form. The study is going to measure if it is really improves the carcinoid features or not. And then the second question I always get from my patient, is it really going to control my tumor growth? I don't know. We really don't know at this point, and that's why we're doing the study. Again, theoretically, it is the same medication, so it's supposedly we see some benefit, but we cannot claim that until we finish the study. We opened the study at Sideman. We put some patients on it. We're having some definitely positive impression, but we have to wait until the study finish and see which dose is better for the patient, 40 or 80 milligram, and it does really control the carcinoid features or not. I assume after that, the plan to do another study to show if it delays the tumor growth as well or not. Another oral option, what we call the mycapsa, it's another oral form of octreotide. The efficacy has already proven for pituitary tumors and acromegaly. And the phase 1 study did show it is safe, and it's going forward now with the phase 3 study. So that's the second oral option for somatostatin analog. And this is, again, we're still in the option of somatostatin analog. We did not go anywhere else. So we have paltusotine, we have the mycapsa. Both of them are choices, oral choices for patients who have carcinoid features and having somatostatin receptor positive neuroendocrine tumors. The third one is the CAM2029. It's a self-administrated subcutaneous octreotide. So the octreotide that we have now, the long-acting one, it is the one in deep intramuscular. Some patients tolerated well, some patients having a lot of pain, abscess formation. So to have an option that you can give the same long-acting covering every 2 weeks, subcutaneous at home, that's definitely another option, may help our patients that they have carcinoid features and having metastatic well-differentiated GEP-NETs as well. So the study is going for this subcutaneous injection. When they did the prelim data, it did show that it's stable at the room temperature compared to the octreotide that you have to get it 30 minutes out of the fridge before the patient come, and make sure you give it very slowly. The blood levels was almost 500% more than the octreotide, the long-acting, and very similar equivalent side effects. So that will be another definitely good, easier option for our patient just to give injections for themselves at home by using this new treatment. But again, the study is still going, and we are not sure really what will be the results. So this is a phase 3 study, which is gonna basically examine the CAM2029 20 milligram against either octreotide or lenalidomide, which is the standard of care. So before we go to the next step, so we have the octreotide and lenalidomide as a standard of care. We have the paltusotine, we have the Mycapssa, the oral versions, and we have the CAM2029, which is the auto injection subcutaneous. So 3 options for 3 trials. We think some of them is going to change the landscape of how we treat our patients. Going forward, if the patient progresses in somatostatin analog, in 2018, the FDA approved the PRRT, which is peptide receptor radionuclide therapy. The idea is very simple. It is the same somatostatin analog. We attach it with a radioligand material, radioactive material. It will go to any neuroendocrine tumors in your body, which it does express the receptor, attach to it, and deliver very concentrated radiation. So it's supposedly to be more aggressive than the somatostatin analog, not only for controlling your cancer, but also with some shrinkage as well. So when they did the study, which is the NETTER-1 study, they did show a big difference when they compare it with the high-dose octreotide. So the patient who starts the somatostatin analog, even when you increase it to the high dose and you compare it with the lutetium-177, there was significant improvement in the progression-free survival with almost 80% decrease in the risk of death or progression. Overall, most of the patients tolerated very well. The most common side effects are fatigue, nausea. It can cause decrease of specific white blood cells, including lymphopenia, which is the lymphocytes. And in the study, about 1.5 to 2% develop higher risk side effect, which is myelodysplastic syndrome and acute leukemia. But then recently, we have a study showing if you are a patient who took the CAPTEM, the chemotherapy, and then you took the PRRT after that, the risk increased from 2% up to 10%. So usually my patient who did the chemotherapy before, who are eligible to have the PRRT, I usually discuss with them this point, because you need to have an increased risk in the acute leukemia if you already took any chemotherapy before the PRRT. So what are the clinical trials in the era of the radionuclide therapy that we are expecting? There is some trials are gonna provide new type of treatment, what we call the alpha-targeted therapy. I'm gonna discuss it in a minute. There is some trials is going to ask some questions that we don't know about. For example, the NETTER-1 trial was mainly in grade 1 and in the mid-gut tumors, the small bowel neuroendocrine tumors. Does it work the same for the extra mid-gut tumors or not? Does it work the same for grade 2 and grade 3 neuroendocrine tumor? Who said it's better to give the PRRT first instead of giving everolimus, Sutent, or CAPTEM? Some of the study that you are going to see is not going to provide a new treatment, it's going to answer some of these questions. So this is one of them, which is the NETTER-2 trial. They already finished that trial. We're just waiting for the final analysis. And it's basically to answer the question, does using PRRT in naive patient in the beginning as a first line, or using them in a grade 2 and grade 3 will provide the same benefit what we saw in the NETTER-1 trial. So this is definitely one of the very interesting trials that are going to answer this question. We're going to change also the landscape of treatment because, when the final analysis come back positive, you can use it for mid-gut and extra mid-gut when you have really now a solid data about it. You can use it first line, and you can use it in patient with high grade 3. We're expecting overall that the patient with high grade 3 will have less benefit compared to grade 1 and grade 2, but we don't really have any prospective trial to answer this question. So it's a very interesting study that I think is going to do a lot of changes how we treat our patients. Another study has been published comparing the PRRT with sunitinib. And they compare it because no one knows what is the good sequence for this treatment. So the study basically evaluated the anti-tumor efficacy of PRRT compared to the patient who got the Sutent. And you can see that the median progression-free survival was significantly higher for PRRT, about 20.7 months compared to 11 months in sunitinib. And that's why we always trying to treat our patient as early as enough. So if your patient progresses in somatostatin analog, they are good qualified for PRRT. We usually would like to treat this patient early than just putting them in another types of treatment. So this is another study giving us or answering the question that if you can do the PRRT as early enough will be definitely better than just put it later because it provides better progression-free survival compared to the regular standard of care. Another two studies, the COMPETE and the COMPOSE study. Again, they are not providing a new treatment. They are answering a specific question about the sequencing. So the COMPETE trial is a randomized control phase 3 trial. It's going to evaluate the lutetium-177 with everolimus. And the primary endpoint is progression-free survival. Again, just to show us which one is better to start first. The same with the COMPOSE study, that it's also evaluating the lutetium-177 against some standard of care option, including the CAPTEM, everolimus, or FOLFOX, and that's according to the investigator choice. But that's also including the patient who have a grade 3 as well. So it's answering a couple of questions to confirm, does lutetium-177 work for this high grade? Does it better to do it earlier compared to the regular standard of care? So I show you 3 trials. None of them is introducing new treatment. One of them is going to answer, is it working for grade 2 or 3 or not, and can you use it in naive patient or not. One of them is comparing with everolimus, and the other comparing with other standard of care options. So these 3 trials, I encourage you to participate in the trials. A couple of them already has been done and finished. But it will give you, it will benefit you to know which one we can use first, benefit other patients as well to have this piece of information. The other trials, I'm going to show you a couple of trials that's introducing new concept of treatment. So alpha-targeted therapy and beta. Beta is what we use in the lutetium-177 right now. As you see, it delays the progression of the cancer in the NETTER-1 trial. The response rate was 18%. The new FDA assessment of response was about 14 to 15%. So it doesn't shrink the cancer as you expect, but it does provide a long time for delayed progression of the cancer. The alpha-targeted therapy causes a double break of the double strand of the DNA. So it really breaks the 2 strands of the DNA of the cancer, which is very hard for the cancer cell to recover itself again. So we assume it will supposedly to be much more aggressive in terms of shrinking the cancer. What are the side effects? We don't know exactly yet. So they did the phase 1 study. It was very impressive. The response rate was up to 83%. And the side effect in the study did not really differ significantly from the PRRT. So this was the phase 1 study using the lead-212, and it was very interesting to see this overall response rate. So now we have 2 studies for using this alpha-targeted therapy. In naive patients, they call it naive, but you have to be progressed on somatostatin analog. But in naive, which means you did not get the PRRT before, you did not get the lutetium-177 before. This is a phase 2 study that I think they either completed or they don't have another spots anymore, because I send a lot of my patients, they have been told there is no enough spots available anymore. This is patient who well-differentiated neuroendocrine tumors, who are, again, naive. They never got any PRRT before, but they did progress on somatostatin analog, and they are going to receive the lead-212 for 4 cycles. So if this study is going to introduce definitely a new type of treatment, which is the alpha-targeted therapy. Another study, which is ACTION-1 study, and this is using the actinium-225. It's just another form of the alpha-targeted therapy, and this for the patient who did progress on the PRRT. So if you're one of the patients who got the somatostatin analog, PRRT, or even another treatment before, and you did progress on them, this will be the right alpha-targeted therapy to be qualified for. And it's going to basically compare the actinium-225 with another options of the standard of care like everolimus or Sutent. They already finished the phase 1 study in 17 patients, and there is no significant side effects or dose-limited toxicity, which is very promising. Now we are in the phase 3 study for these patients. So before we go to targeted therapy, We finished the somatostatin analog. We have 3 new options. We finished the PRRT. We have 3 trials. It's going to answer very important questions. But you also have a couple of new options, in a phase 2 and a phase 3 right now with the alpha targeted therapy. The targeted therapy itself, whether the mTOR, which is a protein, correlate with the cell growth and proliferation. So if you can inhibit it, you can inhibit the tumor growth and proliferation as well. And they did 3 studies. This is picture by itself. It did show you how heterogeneous and how different are the neuroendocrine tumors. They do not respond the same. The first trial was the RADIANT-2 trial, mainly in patients with functional tumor, lung and mid-gut neuroendocrine tumor. And you can see the 2 curves are almost touching each other. So the study was almost negative. So this type of patient, if you have a functional mid-gut neuroendocrine tumor, I would be very hesitant to start everolimus in the beginning. This would be one of my last options. The second one is RADIANT-3 trial, was mainly in patients with pancreatic neuroendocrine tumors. And you can see they definitely benefit. It have a significant increase and improvement in the progression-free survival. And the third one was RADIANT-4 trial in patients with non-functional neuroendocrine tumors. And also this patient did benefit. So if you are a patient with non-functional neuroendocrine tumor or pancreatic neuroendocrine tumor, this will be a right treatment for you to delay the progression of your cancer. It ranges between 11 and 12 months, and then I see some of the patients start progressing as well. What is the most common side effect of everolimus? Again, everolimus is using as one of immunosuppressive medication as well, so it can cause a lot of stomatitis, ulcers in the mouth. Usually we use some steroids, mouthwash, to prevent that. It can cause a lot of diarrhea as well. Very rare, but it can happen. It can cause inflammation in the lung, what we call pneumonitis. Believe it or not, it can be life-threatening. So if you are a patient, already have some underlying lung disease, you have to consult your physician before you start the everolimus. There is some data that showing in breast cancer, not in neuroendocrine tumors, there is not a big difference between using 5 and 10 milligram. And when I ask a lot of my colleagues, some of them started with 10 milligram and then they decrease slowly according to how the side effects the patient have. For me, I do the opposite. I start with 5 milligram and sometimes I increase it slowly as well. Because the study in the breast cancer did not show any significant difference in progression-free survival, but there is a significant differences in the toxicity of everolimus between 5 and 10 milligram. So another one is the anti-angiogenesis with the sunitinib. This is one of the medication has been used in what we call the anti-VEGF. It basically works in the blood supply of the cancer itself. And it has been shown in other cancers that it delays the progression of the cancer. We have a phase 3 study in pancreatic neuroendocrine tumor against placebo. It was also a positive study. It did show a delay in the progression. We do not have the same data for some patients with either a small bowel or lung neuroendocrine tumor. So sunitinib are mainly oral treatment for some patients who have a pancreatic neuroendocrine tumor. Usually I use it as a 3rd line or further if they did progress on somatostatin analog and PRRT. So what are the new treatment coming in the era of the targeted therapy? We just have some of the good news about the cabinet trial using the cabozantinib, one of the multi-kinase inhibitor as well. That's an oral medication. And they compare it against placebo. And the study seems to be a positive study. We don't have the final results published yet, but this is one of the options that's going to be approved by the FDA for patients who did progress maybe in somatostatin analog, PRRT, and even other targeted therapy as well. So that's one of the options for pancreatic and extrapancreatic neuroendocrine tumor that are going to be approved very soon for metastatic refractory patients. Sorafenib was another very promising medication, again, another oral multi-kinase inhibitor that when they did the study in China, it was positive for both pancreatic and extrapancreatic neuroendocrine tumor. It delays the progression of the cancer. However, the FDA had some concerns that most of the patients, again, were from China, and they require to have the same study in the US before they can approve the sorafenib. But the data was definitely very, very promising. And actually, when they even combine it with some of the immunotherapy for high-grade neuroendocrine tumors, the phase 2 was very promising as well. So this is one of the medication, if the company gonna plan for another further study in the US, I think this will be one of the good options for our patients. Okay, chemotherapy, and basically I'm going to concentrate here on the capecitabine and temozolomide. We use it mainly for patients with pancreatic neuroendocrine tumor, especially the one who have a high tumor burden. And we have two studies actually proving the benefit for using CAPTEM. One of them was a retrospective study. This was the initial one. Has been done with Dr. Strasberg, and it did show significant decrease in the size and shrinkage of the neuroendocrine tumor with a response rate approaching between 40 and 50%. And then after that, we did have the prospective trial, which is comparing the CAPTEM against the temozolomide and also was positive study. So when do we use the CAPTEM chemotherapy for patients who have pancreatic neuroendocrine tumors, are well differentiated, especially those with high tumor burden, or some of the patients that we would like to shrink the cancer and then take them after that to what we call cytoreduction surgery. Just remove the primary tumor and some of the lesion in the pancreas or even outside the pancreas. Some of the patients will not have the same response. Like when you look at this picture up and down, that's before the chemo and after the chemo, which is very promising. But not all the patients will have the same response. Some patients will only have a stable disease. Again, one of the side effects of any chemotherapy, including fatigue, nausea, vomiting, it can affect your blood work, can put you at high risk of some blood toxicity, including MDS and acute leukemia. So you have to be very careful, especially if you put this patient as one of the eligible patients for PRRT in the future. Do we have the same data for a small bowel or lung neuroendocrine tumor? Unfortunately, we do not have the same level. The patient are having significant suboptimal response if you are a small bowel or you have lung neuroendocrine tumor. There is some data showing that if you have a high grade 3, well-differentiated small bowel or lung, you do benefit from the CAPTEM. You have better response compared to the earlier grade 1 and grade 2. So I can consider it for some of my patients, but usually not my first option for the extra pancreatic neuroendocrine tumors. So do we have any new chemotherapy coming to the field? The study that we have is not going to introduce a new treatment. It's going to answer a question. If you have a localized or locally advanced but limited pancreatic neuroendocrine tumor, if we removed it by surgery, should you take chemotherapy after that or not? That's the trend of our practice in most of other cancer. So if you are a patient with a colon cancer, even stage 2 and 3, once you get the surgery, you most probably are going to receive about 6 months of chemotherapy after that to decrease the chance of the cancer coming back and improve the overall outcome. We never have the same data to support using the CAPTEM after surgery in neuroendocrine tumor. So this will be a randomized phase 2 study for patients who have resected well-differentiated neuroendocrine tumor, even if you have up to 5 lesions in the liver, but you can have ablation and you can have surgery for your primary pancreas, you still can go to this trial as well. And this will be 4 cycles of CAPTEM. Remember, in the metastatic setting, we can use it up to a year, up to 12 cycles. For the adjuvant treatment, it's only 4 cycles, and it will be, again, as the placebo. So some patient will be in placebo, some patient will be on 4 cycles of CAPTEM. And the primary endpoint will be recurrence-free survival. Does it really decrease the chance of recurrence and delay the time of the cancer to come back? And so we have a specific score. You have to be a grade 2 neuroendocrine tumor. The tumor size is like more than 2 centimeters, a specific Ki-67 lymph node, and then you calculate this score and see if you are patient eligible or not. So this is another study going to answer a question, not necessarily providing a new treatment. So before I summarize and go to this slide, so we talk about somatostatin analog, and we introduce 3 types of options. So if you are a patient who's taking somatostatin analog and you have a stable disease, you can ask your physician if you are qualified for one of these oral medication or even the study for the auto-injection. If you are a patient on PRRT and you did progress, you have an option of alpha-targeted therapy. If you are a patient who are naive and just finished the somatostatin analog, you may be eligible for the naive treatment, the alpha-targeted therapy using the lead-212. If you are a patient who did progress in PRRT and somatostatin analog, you have a lot of options, including hopefully very soon the cabozantinib, or if you have another targeted therapy at your institution, I think it would make sense to ask about that. Neuroendocrine tumors are very different types of cancers. You have to find a program which include medical oncology, surgical oncology, pathologist, to get everything right from the beginning, including your diagnosis. You have to know what's your differentiation, what's your grade, if you do have a good somatostatin receptors or not. You have to ask about your tumor bulk. How many lesions do you have? Are you qualified to meet your surgical oncology and ask for cytoreduction? You also have to ask what's your genetics, especially if you are a patient with pancreatic neuroendocrine tumor. It makes a difference for some of the imaging for follow-up. Definitely, if you are a patient with functional tumor, you have to ask for what type of treatment to receive to control your symptoms, because it definitely significantly improves the quality of life and make you tolerate more treatments. A lot of treatment, as you see, are coming to the field. I think this is one of the fields that have a lot of progression going on. At least one treatment is going to be approved very soon by the FDA, and some of other alpha-targeted therapy will be very excited and are going to change the landscape for how we treat our patients. So make sure that you ask these questions, make sure that you see a program for neuroendocrine tumor, and always try to contribute to the clinical trials. Thank you.